what happens in this ablation is, we have got something known as radio frequency ablation, the most common mucosal ablation technique. What do you mean by ablation? Here, they use the heat generated by radio wave, and read into distress. Okay, that's all. Heat generated by the radio wave, and they target the tissues and they destroy the tissue. Okay, now you have the one type of radio frequency ablation, that is something known as halo, where 360 degrees circumference it can do. For 90 degrees, 60 degrees, it is used for the islands of Barrett's esophagus. Okay, now the efficacy means how much potential it is. The efficacy of radio frequency ablation decreases. When it decreases it, if you have large hiatal hernia, or you have a long segmental Barrett's esophagus, or narrow esophagus, or esophagitis. Okay, esophagitis, narrow esophagus, long segmented Barrett's esophagus, large hiatus hernia, the efficacy of radio frequency ablation decreases. Okay, ablation decreases. Okay, in which all conditions? One is narrow esophagus, esophagitis, long segment Barrett's esophagus, large hiatal hernia, the efficacy decreases. Okay, now the next important point we have got something known as other mechanism for the high grade dysplasia is, we have something known as vagal sparing esophagectomy. What happens, and what do you mean by vagal sparing esophagectomy? We're going to spare this vagus now. Okay, now what exactly happened is, you give an incision at this stomach. Now what happened is, you pass a you pass a wire here where we use for the stripping, right? It is a stripper. We pass the stripper from the stomach, it goes to the esophagus. Now what happens, it covers, the stripper covers, you change the knob. Okay, it is something like this, right? Now you pass here, you change the knob, so that you have a mucosa here, you have a submucosa and muscularis propria. Now what does it strips down, it's come out. Now in this, it spares the vagus nerve, it also spares the left gastric artery. And where does it do this vagal sparing esophagectomy is done in high grade Barrett's esophagus, good, and end stage eclasia cardia and early T1A. I have already discussed you T1A. Okay, that is about the lamina propria, right? You have an muscularis mucosa, right? In these conditions, the high grade Barrett's esophagus, end stage eclasia cardia, early T1A, you can use this vagal sparing esophagectomy, right? Vagal sparing esophagectomy. Now, what are the indications for the vagal sparing esophagectomy? When the Barrett's is more than 8 centimeters, we're going to use this vagal sparing esophagectomy. If the multifocal disease, we're going to use. Severe GERD, we're going to use. Poor esophageal motility, we're going to use this. Large hiatal hernia. So large hiatal hernia, poor esophageal motility, severe GERD, multifocal disease, Barrett's. In these conditions, we're going to use, and these are the same conditions where used for the esophagectomy also, right? So that's all you need to understand. Okay, now even you should also understand the risk factors for the Barrett's esophagus. So the Barrett's esophagus, the risk factors is, you have got something, male is a risk factor. Okay, you have an older male who has obese is smoking, that is increased height. So increased risk is seen. You can see there is an old boy who is a fat of old age guy, tall, fat, obesity, who is smoking, and is a male. All the increased risk. Decreased. Okay, what are the decreased? Alcohol decreases, H. pylori decreases, NSAIDs decrease the risk, statins decreases, fruits decreases, fundoplication decreases, low calcium decreases, low calcium magnesium intake ratio decreases. That means if it is a low calcium, it means a more magnesium intake is advised. Okay, and we should understand that the PPA, not the PPA. PPA, what does it do? It increase the barrier. How does it increase? The PPI increase the hypergastremia. Once it is hypergastremia, ultimately Barrett's esophagus, ultimately adenocarcinoma. So these are the basic risk factors which we need to understand. Okay. Now, let us, which we have already discussed. So let us understand. Let us finish the session by reading these points here. Now, how will you evaluate? It's written that on endoscopy, the tongues of what's squamous columnar mucosa projecting into distal esophagus from the squamo-columnar junction. Okay, so which we have already discussed about the Prague's protocol, MM, that is the width of the circumference barrettes, and M is maximum length of total barrettes, that we have already discussed. And we should also understand there is something on a CITL protocol. Now, what is CITL protocol? We have 4 quadrants biopsies every 2 centimeters from squamo-columnar junction. Okay, from squamous columnar junction. And it's also understand narrow band imaging helps visualize Barrett's esophagus than the conventional, which is of standard mixture of color. So blue and green colors is very important for the to visualize the Barrett's as compared to the conventional white light. So if you observe carefully here, now what is this CETL protocol where 4 quadrants biopsy has been taken. So see, this is a 1 quadrant, 2 quadrant, 3 and 4. So for every 2 centimeters, what you do is you're going to take the biopsies. Okay, you're going to take the biopsies so that it can give the clear cut the diagnosis. So CETL protocol, 4 quadrant biopsies every 2 centimeters from where? From squamo-columnar junction. It's from the squamo-columnar junction. Now, what are the histological types of Barrett's? The histological type of Barrett's can be intestinal type, I have told you gallbladder cells, can be a cardiac type, that is cardiac type, and that is mucous glands are present. Then oxyntocardiac type, where the oxyntic or the parietal cells are present or the cardiac glands are present. Now, what is the treatment of this Barrett's esophagus? Treatment of reflex is PPI, endoscopic ablation for dysplastic Barrett's, which I have told you, radiofrequency ablation, cryotherapy. Combining ablation of Barrett's esophagus with anti-reflex surgeries, then endoscopic mucosal resection, endoscopic submucosal dissection for nodular Barrett's esophagus, which I have already discussed. Esophagectomy, Barrett esophagus nodule. In which condition you're gonna do this esophagectomy? If a Barrett's esophagus nodules, if the stage is T1B, okay, you're gonna use this esophagectomy, persistent Barrett's esophagus with high grade dysplasia, multiple ablation attempts, and you have got complete complicated ulcers, strictures, ulcers interactable to in what is not reactive to conservative management. So these are treatment which we need to understand in the Barrett's esophagus. It's all for now. Thank you.